Hi, everyone, and welcome to the Community Engagement Series. My name is Priscilla Medeiros. I'm the Knowledge Mobilization and Community Engagement Specialist at the Edwin S.H. Leong Center for Healthy Children, as well as your moderator for the session. I'm very excited to introduce our speaker for today's webinar. We're joined by Dr. Andrea Tricco, who's a scientist and director of the Knowledge Synthesis Team in the Knowledge Translation Program at the Shing Knowledge Institute at St. Michael's Hospital, Unity Health, Toronto. She's also an associate professor at the University of Toronto in the Dalla Lana School of Public Health and Institute of Health Policy, Management, and Evaluation. She currently holds a Tier 2 Canada Research Chair in Knowledge Synthesis. Her research interests are related to responding to decision makers through knowledge synthesis. Her research focuses on advancing the science of knowledge synthesis, and she's leading research projects related to rapid reviews, network meta-analysis, as well as scoping reviews. So thank you so much, Dr. Tricco, for joining us. I'm now going to pass it off to you for our presentation.
Great. Thank you so much. And such an honor and a pleasure to be here with everyone today. So today I'm going to be talking a little bit about our strategy for patient-oriented research, or SPOR Evidence Alliance initiative. And this initiative has had a huge focus on patient as well as community engagement. So I do want to start off with a land acknowledgement. So our central coordinating office is located on land that is now known as Toronto or Toronto. And it is a traditional territory of many groups. So Mississaugas of the Credit and the Chippewa Ojibwe of the Anishinaabe, as well as the Haudenosaunee and the Wendat. And then just for me personally, I want to say that I am committed to continuing to learn and respect the history and the culture of the communities that have come before and presently reside here, as well as acknowledging the harms of the past as well as that happen today. And dedicating myself to work with and listening to First Nations, Inuit, and Métis communities, trying to work towards reconciliation and partnership. So I am a white settler on this land, and I'm very grateful to have the opportunity to live, work, and play on this land. So today we're going to talk a little bit about the SPOR Evidence Alliance, so that you gain an understanding of some of the activities that we focus on. As well as let you know how we engage patient and public partners, as well as members of the community in everything that we do, and how we collaborate with decision makers. So this would be collaborating with diverse decision makers, as well as researchers and trainees on all the projects that we work from, including those that actually come from the community. So starting off a little bit about our main activities. So we were funded by the Canadian Institutes of Health Research in 2017. And so we're a pan-Canadian partnership of researchers, patients, and the community, as well as healthcare providers and health system decision makers. And we're trying to promote a Canadian health system that is increasingly informed and continuously improved using the scientific evidence. So our main product that we provide is a research query service. So we call these demand-driven. So these are research projects that are coming from decision makers that have an evidence need. So we do get projects that come from policy decision makers, as well as projects that come from anyone, whether it's me or you, or the public, or other patient and public partners in the community. And this is very much focused on the local context that this is being conducted. We also provide training and capacity building, and we're trying to build a culture of learning and innovation, and also try to advance the science. So increasing the visibility and reach of our health research, and in particular, advocacy, showing the importance of patient-oriented research, as well as the importance of patient engagement and engaging with the community, in particular with trying to reduce health inequities. So in terms of our membership, about 13% are patient and community members. The majority are researchers, so 53%. Again, it is a research initiative, but we also have 15% policymakers and health system decision managers, and we also have about 20% of trainees. And you'll see that we try to have a broad distribution across Canada, and we do have some international members as well. So getting right into this, so when we work with patient partners and other decision makers, we try to use a co-creation approach. So this is really where we are coming up with the project together. So of course, as researchers, we have our PhDs or our master's training, and we're highly specialized at doing research. However, we have to value the diversity of other perspectives and other strengths that different people bring to the team. So whether it's those with lived experience, whether it's those who are living in the community and working in the community and trying to come up with solutions for the community, whether it's policymakers that are trying to set the policy at different levels of our health system. These are all different decision makers that we can produce our research findings with. So co-creation, it's a collaborative generation of knowledge by academics who work alongside stakeholders from other sectors. I personally don't like the term stakeholders because it's not culturally safe in Canada because it does have historical roots in colonialism. So instead, we prefer to use the terminology that I'm using today as decision makers. So the spirit of this is to invite multidisciplinary and diverse knowledge users or decision makers who come as equal members of the research team. And again, everyone is coming with their own expertise, and we're producing research together, and everyone has to have a sense of ownership so that they do feel that this is something that we have done together. When we think about knowledge translation or knowledge mobilization, there's two types. So end of grant, this is how it has traditionally been done in the research paradigm, where you conduct your research and then at the end of it, you just try to go to a conference and maybe publish your paper and then call it a day. Or there's integrated knowledge translation, and this is when you have your decision maker or your audience or your end users engaged throughout every step of what you do. And this is really getting towards community-based participatory research is very similar to integrated knowledge translation. So it's a lot closer to that than end of grant knowledge translation. And then again, this is really trying to work together as a team and really focused on the end product that comes together. And really by working together, the end product is much greater than us as researchers doing this all on our own. So when we think about who are the people we can work with or who can we co-create with, the three main categories are patient and community members, healthcare providers, so those would be your clinicians, whether they're medical doctors, whether they are physiotherapists or chiropractors or whoever you are working with that they're providing care, as well as policy decision makers. And when we talk about patient partners, we use this very, very broadly. And so we would include family members and informal caregivers in that as well. And that would be consistent with how CIHR has defined a patient. So the goal is to engage all of these different categories in each study. So having these different areas of expertise. And everyone would receive co-authorship. So the researchers and the patient and community members and the policymakers and healthcare providers and the trainees. So we want to make sure that everyone does feel that they contributed intellectually to the project and that they brought their expertise to the project and that they have co-owned and co-created this project that they will go on to publish together. And I've already talked a little bit about the terminology that we like to use, and a knowledge user is defined as someone who's likely to be able to use the research results to make informed decisions about health policies, programs, and/or practices. So this was a scoping review that we published in 2018, focused more on policymakers, but it can be broadened out to other decision makers as well. So you can think about at each step of your research process, what is their role? So maybe at some steps you want them to have more of an advisory role, you want them to be a key informant, or maybe they are a team member on your project. What type of method do you want to engage them? Will you do online surveys? Will you have team meetings? Will you do a more formal Delphi? Will you just engage through email? Will it be a combination? It really depends on what your purpose is and what you need to get from these individuals at different time points of the process. And again, will you be doing this through Zoom? Will you be using email, phone? How will you be, what are the modes of engagement? So anytime you're thinking about your research project and when you want to engage with knowledge users, it's really important to think about what their roles will be and very clearly set that out from the very beginning, what the methods will be for your engagement and what the mode will be. And this is a figure from CIHR. So if you think about it, we can co-create at each step of the life cycle. So at priority setting and planning, developing your research proposal, reviewing scientifically the proposal, ethics review for some types of research, oversight and leadership or co-leadership of a research project, recruiting participants, data collection, analysis and interpretation, as well as knowledge translation and exchange, and then evaluation and quality assurance. So you can actually engage with decision makers at every single step here of the research life cycle. That to be said, there are some barriers and some facilitators that we need to be aware of. This was specific to knowledge synthesis, but if we look at research in other types of areas and research methods, we do see something very similar here. So we saw that knowledge user expertise is a facilitator in about 17% of the projects or the studies included, and early relationship building about 10%. However, the largest barrier was time. So we know that when we are doing this work, it does take additional time in our research process. And also, if you think about it, it takes time to communicate. And a lot of times, based on our experience, the first thing to go is the communication. So we have these amazing decision makers that we are co-creating a project with, and we forget about them because we don't have time to even email them and give them an update. So that unfortunately is something you have to take into consideration when you're doing this work. And if you think about some tips here, so when you're working with decision makers, you want to think about developing a plan for engagement. You have to have appropriate resources, and I'll be talking about this in a few slides, as well as capacity building. How will you recruit and retain, especially with those who have lived experience? So whether they have it personally or they are a caregiver, perhaps there are times where the illness may make them unable to participate fully. And so what will you do in those times? So you have to think this through in the very beginning. Consider the barriers. So how will you make sure that when you don't have any time that you do communicate properly and make sure that people feel included? Create a very positive environment for people, showing appropriate appreciation, and then also how do you report your engagement and how do you evaluate it? And I'm going to touch base on all of these different aspects as we go along. So this is just like a nice little snapshot or a nice little picture of some of the things that I'm going to be speaking about. So focused more on patient-oriented research. So 50% of patients don't get the treatments that they require. Sometimes they get treatment that is not required or actually harmful. And because of all of these limitations, the CIHR introduced SPOR in 2011. And really it was so that the right patient receives the right intervention at the right time. And so sometimes we get asked as researchers, why would we engage with patients and community members on our projects? So it's really important that that we think of them as decision makers. They have lived experience. This is actually a specific type of expertise that is very, very valuable to your research projects. I'm not sure if you've heard the terminology, but nothing about us without us. It's really important that we do include people who have lived experience. It can lead to additional opportunities, maybe research funding and other collaborations in the future, also opportunities for trainees to learn. So really for our research to be relevant, we really need to, and also, I would say that with time, as time goes on, our health problems are becoming more complex, and we really need complex solutions to them. And we really need the diversity and the breadth of people coming together with different expertise to solve these really, really complex problems that we're working on. So how can we do this? So hopefully we all believe that this is important, but how do we actually do that? So what we did with the SPOR Evidence Alliance is that we actually have a mechanism where patient and community members can submit topics that are prioritized, and then we provide funding for them to co-lead those projects. So that's one way that we engage with patients in the community on our research projects. We also have included patient and community members on our governance structure. So we have 4 co-chairs and we have 13 that have been part of the governance structure. We have an annual seed grant competition for trainees. And so we have patients and community act as peer reviewers, talking about the impact of the project and coming up from the perspective of a decision maker and how important would this project be. So we actually have a different set of criteria for them to peer review the projects that are submitted through the seed grant. And also on our priority setting panel. So that's when we're thinking about those projects. So the 98 projects that came from the community and patient partners, and then we went on to priority set those. And then we had 338 patient and community engagements across 100 research projects, and we also do quite a bit of capacity building. So we've had 700 plus learning engagements as well. So we have 2 courses that were co-led by patients and delivered to patients. We've also evaluated our patient engagement. So we've written 2 published evaluation papers on that. And then we have 4 principal patient partners who are knowledge users, as well as 14 knowledge users on our CIHR grant. So this is like a nice little snapshot of showing you how we have tried to engage patient and community partners at every single level of our entire research initiative. So in 2021, we were doing a lot of rapid reviews for policymakers on COVID. There was a lot of them. And so we needed to provide our patient and public partners with capacity building on how can we do this in an effective way. So we had a course that was delivered in 2021. And in 2022, this was expanded to different types of knowledge synthesis because we've had patient and public partners engage not only in rapid reviews, but also in systematic reviews and scoping reviews and network meta-analysis, which I won't get into the definition for all of them, but just to know that rapid reviews, we basically take a systematic review that would take 12 months and we try to conduct it within 3 months. But during COVID, we were actually doing our rapid reviews within 5 days. And we were able to engage with patient and public partners in these rapid turnarounds where we produced a report to a policy decision maker within 5 days. And we're still able to effectively engage with patient and public and the community in those projects. So we provided these 2 courses. We had 2 experienced patient partners who led the courses and helped curate the materials. And overall, we found that 90% of participants felt that the course actually helped them achieve their learning goals, and they found that their learning experience was valuable. So if you are planning to do work in this space, you definitely have to provide capacity building to the patients as well as those with lived experience and those coming from the community. However, all that to say, you also have to provide capacity building to the researchers. So that's very important. So we've developed a series of webinars. You can find them all on our website, all kinds of templates and guidance documents where we ask the research teams to consider many different facets while they're doing the research. And then we have this co-leadership model, as I said, where the patient partner or those from the community who submitted the topic, if their topic was prioritized, they co-lead that project. So they kind of become a co-PI with the researcher, and they're coming with their lived experience to co-lead that. And this is a very different model of doing research than what most people are typically used to. So because of that, we provide quite a bit of resources specifically for that product. So we have quite a few resources on our website. You can find the links here. And also to say, I will talk about in a few slides some more support that we provide for this model, because as we said, it is quite in depth and it is different than what we're typically used to. We do have a series of papers that we published in the Facets Journal, so we can talk, you can look through there, and we have a paper that introduces the Alliance as well as our governance structure. And then we also have a paper where we talk about the query services and talking about that co-creation model that we use. And then we also have a nice evaluation of the patient and public engagement in all activities of the SPOR Alliance. So if you're interested in learning more, you can consult these 4 papers in the Facets Journal. And just to say that because we are including diverse members on our research teams, we actually have to think about equity, diversity, and inclusion in our projects. And I would advocate that we need to consider this for all of our projects. So even, you may think, and I get this a lot from research as well, my topic has nothing to do with equity. I think if you're doing any type of health research in Canada or anywhere, you just naturally have equity that you have to consider. So especially if we're doing knowledge synthesis, which is a team-based science. And if you're doing knowledge translation, you need a team to do this work. So we're including people with diverse lived experiences. So we have researchers, research staff, trainees, patient partners or community members, healthcare providers, and policymakers. And we really need to create an accountable space where people feel that they can contribute. That this doesn't necessarily mean that we agree with all of your ideas, but we want everyone to feel respected and that we really, at the end of the day, everyone wants to feel that they've been heard. So we need people to be able to express their opinions in a way that is respectful, and in a way that people have felt that they have been heard. So when we are cutting people off or we are, treating them differently or in a certain way, or spending all of our time talking. Like I have some colleagues that just talk the whole hour that we're having a team meeting. That it's not really allowing people to feel that they can share their ideas. And if we do see, microaggressions and whatnot in our meetings, we do have to find ways to deal with that in a safe way where people feel that they can contribute meaningfully. At the end of the day, we're all here to improve patient outcomes if you're working in health research. And also our system is plagued with health inequities. So I would say that everything that we do needs to be rooted in an equity, diversity, and inclusion lens. So how can we do this? This is from knowledge synthesis because that's the area that my Canada Research Chair is in, and that's where I've devoted my past 20 years of my career in. But you can think about this for any type of research design. So when you're developing your protocol, you want to make sure that your team is representative of the topic. We have a self-reflective exercise that is on the SPOR Evidence Alliance website where you need to consider the power and oppression that you faced in your life where you may have experienced advantage or disadvantage. And the purpose of that is to think about where are you, what's your positionality on the team? Are there people who may be experiencing disadvantage? And how can we make sure that that everyone is there to share and that people feel that they are respected, that they are equal members of the research team, and that they're being heard. So that's why we do that exercise by yourself, and to think about that. You can also consider if equity could be a focus of your project or a sub-focus, and what is your theoretical lens for doing the project. Specific to knowledge synthesis, you can use equity-specific filters or databases. You can think about if your eligibility criteria will focus on any equity dimensions. We like to use the Progress Plus for data abstraction on all of our projects, even projects that people say, well, this has nothing to do with equity. We always try to abstract Progress Plus variables. So that stands for, and I'm going to have a slide on Progress Plus, but it stands for place of residence, religion, occupation, gender, race, education, socioeconomic status, and plus other factors such as age, ability, etc. And we also want to think about the intersection of these demographics. So again, in the reflective exercise, we talk about this and we want people to consider that. You want to see if those studies that you're included were powered correctly for equity, if you're thinking about risk of bias as an example, and then conducting appropriate sex and gender-based analysis, using the PRISMA, which is the preferred reporting item for systematic reviews and meta-analysis for equity if you are doing a knowledge synthesis. If you do any kind of gender-based analysis, there's the sex and gender equity in research guidelines, or the SAGER guidelines, to think about when you're reporting your project. So this gives you some nice tips or ideas on how you can actually embed equity in your research projects. So in terms of when you're working on these diverse teams, you want to co-create the values and guiding principles at your team kickoff meeting. So you want to think about what are the values here? So things like we respect each other, we communicate with respect and kindness and compassion, we listen, and we listen to hear and not to respond. I think as humans, we like to listen so that we can get our viewpoint heard, but really it is being active listening and taking in and paraphrasing and summarizing and making sure there's no misinterpretation. And co-creating a terms of reference for the team, how you're going to operate, as well as policies. So how will you show your appreciation to patients and community members? Will you provide compensation? When will you provide it? How will you provide it? What will the remuneration be? Will you provide them with the opportunity to be an author or an acknowledgement, et cetera, et cetera? And how will you deal with conflicts of interest? So what are conflicts of interest? How will you deal with them? And then again, your self-reflective exercise to think about your lived experience, advantage and disadvantage, and position on the team. And again, thinking about in your team meetings, did everyone, so if you think about Google as an example, they have done some research on what the best teams are. And the best teams are when there's actually shared speaking at those team meetings. So it sounds like something very small, but it's actually really important. So does everyone have an opportunity to say something at your team meeting? And you can even track that at every team meeting. Has everyone been able to contribute? So again, this is thinking about when the flow here of a knowledge synthesis. So how can we make sure that patient and community members are engaged at every single step? And I'm actually going to go into a deep dive of all of these steps. So that's a little snapshot. So for your idea stage, maybe you can have them participate in priority setting exercise. Maybe they can help select what outcomes. You can get them to rank the outcomes that are important to them. And they can feedback on symptoms, treatments, or health conditions, and how we're actually going to be collecting the data. So when you're thinking of your protocol or your idea stage, there are many different facets or aspects that we can get different perspectives on from patient and public partners in the community. During the research conduct, they can become a core member. They can provide feedback, again, on your literature search terms or outcomes or your screening questionnaire or eligibility criteria, data abstraction form, risk of bias, for example. And sometimes we've had patient and public partners help with screening and data abstraction. So sometimes they actually want to get in there and actually do some of the work as well. And I think that that's okay. It's up to you to negotiate that and see what makes sense for your research needs, as well as for their level of interest, as well as for the time that they want. So we try to tailor participation to their needs and to whatever their desires are. So during the interpretation and dissemination, they could provide specific feedback about the results, how we've interpreted them. We can ask them about the key messages. For all of our projects with the SPOR Evidence Alliance, we like to write a one-page plain language summary of the research findings, and we ask the patient and community members to write that one page. And then they can bring those results back to their communities. So this is the nice thing about the co-creation or co-ownership model, in that everyone feels that they own it and people are proud of it. So they want to share the product with their communities, so they can help with that. And then again, we try to make sure that everyone has contributed intellectually so that they can be a co-author on the project. So thinking about these patient-driven research projects, so these are health research topics that come from patients in the community. And so this has enabled a space for research that is curated for patients and community members by patients and community members. So we try to enable an environment of collaborative learning and mutual respect. And so what we do is we have a ranking exercise and a deliberative dialogue with a steering panel. And the steering panel includes patients and community members, researchers, and health system decision makers. And then this is developed into research projects. So we've had 2 exercises where we have done this. So the first time we received 11 topics from patients in the community, and we did a priority setting exercise, and we selected the top 3, and we funded those 3 projects. And again, the funding came from CIHR. Then we did another priority setting exercise where we received, I believe it was 89 topics from patients in the community. And then from those, we selected 20. So it's a pretty in-depth process that we go before we do priority setting. So we actually do literature searches. We see if the project is unique, because we try to reduce research waste. And then we send out for all the topics. Sometimes we have topics that are related, so we try to merge them together. We hold interviews with every single person who has submitted topics to get their feedback on it. And everyone that participates in this actually gets a 1-pager that says, we found these previous reviews on your topic, and we rate the quality of those reviews, and we say whether there's a research gap that needs to be addressed. So the ones that have a research gap, then they go on to be prioritized. So it's a pretty in-depth process that we use, and we try to follow the James Lind Alliance approach. However, it is done a little bit rapidly, and also with the James Lind Alliance approach, that is usually done within one topic, whereas this is done across many different topics. So definitely a modified approach to that. So we have these details available on our website, and just in terms of some quotes that we received from individuals who have participated in this. Patient partners add heart and soul to the project, which I love that one. And this model challenges the research codebook and encourages collaborative learning. It personalizes and humanizes the research process. So people have really valued being a part of this, and it is something that has led to tremendous impact for those who have participated in them. So in terms of the co-leadership model, as we said, we do have to provide a lot of capacity building. So we've had orientation sessions with the researchers, as well as the patient public partners and community members. We also provide quite a bit of support. So for the individuals who are co-leading the project, they get a $1,000 stipend just off the top, and they also get $40 an hour compensation for all of their time. They also get a $500 tech support so that they can use to buy a new computer, for example, and make sure that they can feel fully engaged. And we also have these communities of practice. So the communities of practice are for knowledge sharing, a network and collaboration, capacity and skills development, as well as advocacy. So we do allow for this, and we will be meeting several times over the next year while these 20 projects are being co-led by patient partners and those from the community. We also have an arm where we do Indigenous peoples engagement. So this has been led by Doctors Angela Mashford, as well as Jennifer Walker and Janet Jull. So for examples include a deliberative dialogue where we had 250 learners attend, and there have been also a lot of capacity workshops and podcasts, and a lot of this is found on our SPOR Evidence Alliance website. So, and we've also done projects with community, the Indigenous people communities. So some examples were brain health with regards to food and nutrition, as well as food sovereignty and traditional foods. And we've also done some work in dementia care, as well as colorectal cancer. So we've had some projects on the go with that as well. There is some training that we're offering to all of our members. So we're starting off with the PIs and the governance structure and the patient and public and community partners first, and then we'll be expanding it to others. And so this is, it's addressing systematic anti-Indigenous racism, and it's trying to provide power, privilege, and positionality through critical self-reflection. And so you can see a bit more about this program here through the link. So that is going to be offered in the next couple weeks. And then there's also land-based learning opportunities. So this is where you actually go and spend 3 days on the land, and this is led by Dr. Angela Mashford Pringle, and this is something that we're currently thinking about to offer to some of our members of the SPOR Evidence Alliance. So, and you get to talk with and learn from elders during the 3 days that you spend on the land. So moving on to policy decision makers. So we do a lot of work for policymakers, but we also want to make sure that we have the voice of the lived experience when we're working with policymakers. So when policymakers have a mechanism where they can submit questions and then we match them up with teams and many different resources. So we have an AI enhanced tool, for example, so that we can be more efficient in our projects. We have a right review tool. We have many different resources. And we try to bring the patient and community voice as close to policy decision-making as possible. And we try to include at least 1 to 2 patient and community members as equal members of the team. So sometimes we have to provide capacity building to the decision makers about the importance of including lived experience on their projects. And we have some innovative ways that we do, like for one thing is in our executive summary, we have an area where the patient partner's interpretation of evidence is provided. And then we also have the lay summaries that patient and public partners and those from the community can write. And we share that with the policymakers as well. And we also all attend the meetings together when we're doing the projects. So it has led to some great, really fruitful projects and very relevant for policy decision making. So we've responded to 278 requests since 2018 from 53 different organizations. So this gives you kind of a little bit of a breakdown of those requests. And again, we have the 23 that came from the patients and community included in here as well. And I won't get into this, but just to say we've looked at a wide range of different decisions. So we've looked at even things like food security and looking at childhood poverty in the Northwest Territories, as well as family violence, as well as gun violence in our emergency departments. And then a lot of different public health topics as well. So we've covered a lot of different things here in these 278 queries. And then, of course, each project is a knowledge translation project in itself because we use integrated knowledge translation or a co-creation model. But we also try to publish on our projects as well as do presentations and infographics and other types of knowledge translation and dissemination products. And here's a flavor of some of our decision-making organizations. So things like the Ontario Ministry of Health, Alberta Health, Public Health Agency of Canada, and the World Health Organization. And just to give you some flavor of some of the projects, so something that we did was on for the WHO on maternal and neonatal health. And so for this project, it was led by Dr. Curran at Dalhousie, and this was actually included in their international guidelines and impacting 140 million births per year. We also did some work on gaming disorder, and this was to help develop ICD codes. And this was commissioned by the World Health Organization. It was also cited in a Government of Finland guideline. We did quite a bit of work in COVID, as I mentioned. So one thing is the infection prevention and control in long-term care. And this was used by many different organizations above and beyond the WHO, but many others as well internationally. And we've done some additional COVID work as well, as I mentioned. So this one was used by the Economic and Social Research Institute in Ireland. We also have done some work for the Autism Alliance of Canada. So this has been helping with the Public Health Agency of Canada Autism Strategy as an example. And then we've also done some work, the family violence work that I had mentioned, and then the Indigenous colorectal screening commissioned by the Sioux Lookout First Nation. So for all of these projects, we aim to include patient and public partners. We aim to include those with the lived experience, as well as those who have the content expertise, as well as the policymakers, and try to do co-creation in the projects that come from policymakers as well. This was the one that I was talking about, the workplace violence and emergency departments as well. And just to say some of the quotes, I know that the font is quite small, but one quote here is that working with the SPOR Alliance was a great experience, and that they were able to connect with the team and they refined the question, and patient and family advisors were engaged throughout, and that they were proud of the work that was conducted, and it was to create safer spaces for staff and patients working in emergency departments. And then from the Northwest Territories was that I really like this quote saying, "I want to especially recognize the care the team took to not just meet the ethical obligations as far as their research license, but in carefully managing their interactions with the community members in a culturally safe way, explicitly putting the needs of community participants ahead of any research goal." So just to show that really, this is not tokenistic engagement that we're trying to do. We really are trying to put patient and public partners at the heart of everything that we do. And then just quickly to talk about the next generation of scientists before we have time for a few questions. So we do have a seed grant competition that we held for 3 years, which provided $10,000 to help with different priorities that we had for those years. And just to show the diversity in the seed grant winners. So someone was looking at gender diverse people in clinical practice guidelines, also engaging Métis citizens in the development of healthcare resources, co-creating physical activity programs for children when they're getting treated for cancer, thinking about women's satisfaction with HIV care, et cetera, et cetera. So a lot of really great projects and a lot of really great impact that came through this. We have also hosted 14 clinical research fellows through Evidence Synthesis Ireland. And again, the reason that we do this is because we want to make sure that we have advocacy and make sure that people understand recognize the importance of this model, and we want this model to be used by researchers more broadly. So we've had, many different thousands of learner engagements and learning opportunities. Definitely look at our SPOR Evidence Alliance page. You will see there's sign up for our newsletter and become a member, and you'll see there are a lot of different opportunities that we can. And again, the reason we do this is to train the next generation of scientists so that they continue carrying the torch and continuing finding innovative ways to bring the patient and community voice as close as possible to policy decision-making, and to make sure that they are not left behind, and to make sure that we really are addressing the priorities and needs that come from the community. So before I get into the questions, I do want to acknowledge many, many, many different people who have made this initiative a success and have really helped me with my journey in patient-oriented research and working with community members. So patient partners, Dr. Don Richards, Annette McKinnon, Dr. Amanda Doherty Kirby, as well as Linda Wilhelm, as well as Catherine Stratton, as well as Sai, who's helped me with these slides in the past, as well as Sharmila, who is not on here, but has helped as well as Dr. Strauss, and to the Central Coordinating Office. So Sharmila here is on here, who helped me quite a bit with this presentation, and Wasifa, Angelica, Sabrina, and Jacqueline. And we are funded by CIHR. And if you ever need to reach out to me, you can feel free to reach out to me anytime. I love hearing from you. And if you have any questions that you aren't able to sneak in today, please email me anytime. So Priscilla, with that, I'm going to close the presentation, and I think we have time for some questions now.
Perfect. Well, thank you so much for such a great session. I was taking notes along the way of things that I certainly want to either follow up on or do a bit more of a deeper dive for my own learning within the space. For those who are on the call, please feel free to raise your virtual hands to then unmute yourselves to ask questions that you may have to Dr. Tricco, or please feel free to write your responses in the chat. I'll keep an eye open for them and make sure that they're addressed by our speaker. So I'll give everyone an opportunity to kind of reflect on what you've heard, and perhaps have questions in relation to your own work. And maybe start things off with a bit of a question just to stimulate conversation. I'm actually really excited that you kind of did a bit of a deep dive, walking us through that engagement process and research and what that could look like. It was really nice to see the schematic. And I know for those on the call, there's probably a bit of an iterative process to that. It's not necessarily just a linear approach or checklist that can be applied for doing this work.
Yeah.
My question to you is often, we complete these cycles where we're involved in projects that are 5, 6 years. We get to the knowledge synthesis piece, the end of grant, and then there's that point of saying goodbye. And I'm wondering how you navigate that point of saying goodbye and closing out those relationships in a good way, where you're leaving it open for the potential of working again with one another and not necessarily cutting off that relationship completely, given the amount of work that goes into creating the trust of having folks participate in the work. So I'll give you the floor.
Yeah. Yeah, thanks, Priscilla. That's a great question. So I guess that I've been fortunate with the SPOR Evidence Alliance and that we have 36 teams across the country, and then we have about 60 patient partners that are currently engaged, but that number fluctuates up and down depending on the time. And so because of the infrastructure, we've been able to maintain those relationships. So they are able to do repeat projects and be engaged in different activities. So if you have a large initiative like that, that makes it a little bit easier. But I guess that if you are just doing like one project and working together, then my suggestion would be to have maybe even a project end type of meeting, or like a cupcake meeting, like make it fun. Everyone comes with their own cupcakes or whatever, like a little celebration, and keeping it open, like you said, so that you can continue to work on projects in the future, and maybe even brainstorming at that meeting, if there's a future project that you can work on together again.
Perfect. I see there's a question in the chat of one that I was
Oh,
also thinking of posing. It asks here, how might I become part of the community of practice?
oh yes. So that's a great question. So that the community of practice is only for people who are engaged with those 23 projects at this point. Maybe we'll expand it on, if we have additional funding and whatnot. But it really is for people who are participating in that co-leadership model, because it is so unique and different. And so we did the pilot project with where we had three projects, was kind of like our pilot phase. And the feedback that came from it was that we needed to provide more support. And so that's why we engaged in those community of practice. But right now, they're only limited to the people who are part of the 20 projects that are ongoing right now.
Okay, that's actually very good to know. Something I was also wondering as to whether there was an opportunity for others interested in the space to join the community of
Yeah.
practice. So we'll certainly keep an eye open for that and
Yeah,
register for
100%.
the newsletter, because I'm sure that's
Yeah,
where that type of announcement would be made.
exactly. Exactly. Yeah.
Absolutely. Are there any questions from others on the virtual call? Oh, I see Elise, your hand is raised. Would you like to unmute yourself?
Thanks, Priscilla. Hopefully this isn't too inside baseball and is of interest to others as well. But I was really curious, Dr. Tricco, thank you, first of all, for the great presentation.
Yeah,
I'm
my
really
pleasure.
curious about one thing you quickly mentioned about the governance structure
Yeah.
at the SPOR Evidence Alliance, and
Yeah.
how patient partners are embedded in kind of all the different steering
Mhm.
committees, et cetera. So
Yeah.
I wonder if you could elaborate a little bit more on what that looks like, and also kind of how it came to be. So
Yeah.
was the SPOR Evidence Alliance conceived that way from the start, or was it
Yeah.
something that was kind of intentionally done over time? And what did that look like?
Yeah, thanks so much, Elise. That's a wonderful question. So, our patient partners who were engaged with us from the very beginning of the initiative at the research conceptualization and the protocol writing, they told us that they would rather, instead of being on their own little separate advisory committee, they would rather be embedded into all the committees to build relationships and really feel that they're contributing to all of the facets of the SPOR Evidence Alliance. So we have the training and capacity building committee. We also have the steering committee. We have the international advisory committee. We have the knowledge mobilization committee. And the partnerships committee. So we have various committees, and the patient and public partners were invited to sit on all of them. And then the four of the committees as well, we have a patient and public co-chair, so actually co-leading those committees. So it was intentionally done in that way, at least, so that we could really foster that relationship building piece, as well as I mentioned, making them feel like they are part of something and part of everything, versus, you know, sometimes if they're just on their own in their own separate committee just with them, they felt that that was a bit more of a tokenistic model compared to embedding them across, you know, everything. So that was the feedback that they gave to us. I mean, maybe different people would have different opinions on it, but we used that model over the last 7-8 years, and then it worked really, really well.
Perfect. Thank you so much for that question. That was, you know, another one that I was also thinking through. Or perhaps another question that I might have, if I can, for others,
Yes.
feel free to
Yeah.
write it into the chat, and also please feel free to raise your virtual hand. I'm thinking through, you know, sustainability is a really important piece to knowledge synthesis. And I'm wondering how you approach sustainability from the onset of your work to ensure that it tracks through the research process in a really meaningful way.
Yeah, so that's really helpful. So for us, in terms of sustainability, we try to make sure that we have enough budget and resources to properly fund the projects. I know sometimes people do knowledge synthesis with volunteers, but that's not the model we use. So we typically write a lot of CIHR grants to do that. And we have patient and public partners and the community members engaged from the very proposal and the idea generation stage, and we make sure that we have in our budget adequate compensation for their time. And the model that we're using right now is from CIHR, which is $40 an hour, and then we also provide caregiving. So, you know, if you have people that you have to care for, we also give additional funding for that. And so we try to be very mindful of people's experiences and how they can contribute meaningfully to the projects at each step. And then we have very highly skilled research coordinators who know how to work with different decision-making audiences and with the communications and making sure that people are in touch, and that at every step of the way, like, we're asking them to be engaged and make things very easy for them. So I think the first thing is really making sure you have a plan, an engagement plan from the very beginning, and that you have the proper resources to pay not only your staff, but also to provide compensation if people need that compensation, and making sure you have your policies in place. So we co-create our compensation policies as an example, and we co-create our conflict of interest policy as well, and then co-creating the terms of reference for the project and your core values and principles. So when you do that in a way, it makes it a lot easier to work together, and also helps with sustainability as you're going through. Does that answer your question, Priscilla? Or maybe
It does, yes. I know it
okay.
can be very specific to the project, but there are overarching type elements that people can be considering when thinking about sustainability. So it was nice to hear from your work and your perspective what that looks like as a package.
Yeah. Yes, great. Yeah. Yeah, it's really important. It's good to think about that from the very beginning, of course.
Absolutely. And perhaps something you also mentioned at the start that might be of interest to others is this notion of language, which is incredibly important when working with patient and community partners. In a space such as this, you mentioned you don't utilize the word stakeholders, that it's inappropriate because of its ties to historical roots, and that in fact you use decision maker in place of that. I'm wondering, in your experience in the space of knowledge synthesis, how you stay up to date on the changing of languages and terms that are utilized out there, and navigate those conversations with those that you're working with to ensure that it resonates with their own experiences.
Yeah, that's so important, Priscilla. And I think the first few meetings are actually all about language and terminology. So, like, when we say this is what we mean, right? Because when we say one word, it actually may mean something completely different to others than it is to us. So I think that that's so important, having those kickoff meetings and talking and learning about each other, and providing those definitions from the very beginning. in those project meetings and outlining them in your protocol so that you know that when we say this, this is what we mean. And coming from a very common understanding, because there is sometimes a loss in translation that happens and misinterpretations that can happen when you have such diversity on the team. And you don't want to lose people just because of language. So it is something that, again, sounds very similar, but it's actually is very important because you want to make sure that you're all coming from the same place and that you do understand what you mean. So that's why I say the capacity building is so key. And it's not only capacity building. A lot of people think about, oh, well, it's the patient and public and community that needs to learn. But actually, based on my experience, it's more the researchers who need to learn and it's the policymakers who need to learn. So we need to actually provide them with the capacity building and help make sure that they're aware of what terms we're going to be using, and creating a space where people feel comfortable sharing their opinions about those terms and feeling brave enough to come forward. It takes courage sometimes, especially if you're in a meeting with a policymaker. It might be a challenge to feel that you can actually voice your opinion and say, well, when you say that term, this is what I think. And, this term actually is not culturally safe because of this. And being able to freely share that, those perspectives is so important. And as researchers, it's important for us to be open to feedback. And take it all as a learning and not taking it personally. I've had, because I've been doing this work for many years, I've had, feedback that, oh, when you said this, it was, we felt stigmatized or it was triggering. And that was very hard for me to hear, because, I do pride myself on having good relationships and having good emotional intelligence and taking leadership training and whatnot. But once in a while, we will trigger people, and that's just being a human and having different humans working together. So we have to be okay with that and learn how to apologize and learn how to move forward and take that information as a learning versus taking that very personally. So I think if we set the environment and set the space where people feel comfortable, maybe not even publicly, but at least maybe giving me a phone call and saying, Andrea, I didn't really like when you said this, and what did you mean by that? And having those open conversations, because these things do happen. We did almost 300 projects with the SPOR Evidence Alliance. It happened in a handful of them, but some of them, there was a lot of heated discussions, and we needed to have moderated discussions with that. And these things happen. And I think expecting that it will happen and having processes and strategies for when it happens. And at the end of the day, knowing that everyone is there to do their best and everyone is there for good science and to improve. Reminding people our core value is that, we're going to treat each other with respect, we're going to listen, and we're going to try to do some good work together. Reminding of those core values that you set at the start can really help kind of set the tone and really help if conflicts do arise through the process.
Perfect. Well, I'm cognizant of time. I want to thank you again, Dr. Tricco, for joining us today. For folks who are interested in continuing the conversation, please feel free to reach out to her directly. We can certainly share the contact again in an email. It was absolutely incredible work. I'm quite interested in co-creation, as I assume many on the call are as well. This is just a starting point and certainly not a finishing point of us talking about this. So thank you again for attending the Community Engagement Series. I certainly look forward to seeing everyone at our next event in May. So please stay tuned for those details and have yourselves a wonderful rest of the day. Bye now.
Thank you. Take care.